One of the great issues of band management is who and how can we provide this long-term care for an increasing number of patients. And this has been a challenge both to practices in Australia and of course the United States, etc. Who does the adjustments now and who will be doing them in the future? We look at this slide showing that in the United States the majority of adjustments are done by surgeons, but more and more practices are using physician extenders, nurse practitioners, practice nurses, and some are using primary care physicians, although they're not commonly used in the United States. In Australia, surgeons are doing many of the adjustments, but more commonly general practitioners who are skilled in adjustments in band management are doing more and more of these. In fact, in Australia today, we have many full-time GPs doing this sort of work, and they're very experienced and very good at it. We also have a number of nurse practitioners or nurses that are practice nurses that are able to do adjustments in Australia, although there are issues with payments and to date they're not paid for this particular work. We have to consider how we're going to provide these adjustments as the practice grows. This next figure shows some modelling work that I've done looking at a practice that has one surgeon who's planning to do 200 patients, lap band patients a year. And we can see here over the first 7 years that there is a slow, almost imperceptible increase in the time that's required in the operating theatre or operating room to actually look after these patients. In fact, that curve is rising because 200 a year actually increases slowly because of complications and revisions, etc. But if we actually look at the number of patients that practice is going to see based on how many visits there'll need to be in the first year, second year, third year, lost to follow up, complications, etc., etc., there's an inexorable rise in the number of visits necessary. And if those visits are not occurring, then patients clearly are not being followed appropriately. So we have to think about how we adjust the practice. If a surgeon thinks they're going to do this for 3, 4, 5 years and beyond, they're not going to have any time to see new patients or put in new bands. So how do we cope with this growing load and future growth in the practice? Remember, it's chronic disease management. It's no different to any other chronic disease management. These patients come along and stay with you. Most of the time we can take the load away, most practices take the load off the surgeon by others training. And in Australia we've been very successful with training GPs and other physicians to help us out with this load. Satellite practices can be useful. Training people at a distance to be able to do this work enables you to take the pressure again off the surgeon and treat people at a distance. Some people are considering outsourcing the work of band fills. There can be shared care with medical practitioners, and I think in the future we have to think of linking with weight management services, bariatric services at both public and private level, and we have to think that we need to integrate this with bariatric care. We could also integrate with diabetes services as well. I think we have to think laterally about how we look after chronic disease management in typically a group of patients that don't have a surgical condition. They really have a device that needs monitoring over the long term.